Hello and welcome to Expanding Access to Personal Care and Homemaker, Respite, and Asthma Remediation Services under Medicaid. This is all part of our CalAIM Community Supports Early Adopter Series, made possible by the California Healthcare Foundation. Next slide. During our session today, we will have a moderated Q&A panel. So if you have questions, just drop it into that box that says Q&A. We will also have slides available to prompt that often first question. Next slide. So today we are zooming in on 3 services and 1 partnership between a managed care plan in California, Kern Family Healthcare, and a community partner, SD Healthcare Consulting. So we'll have presentations from those 2 organizations and then a moderated Q&A doing a deep dive on the services that we're discussing today. Next slide. So if you are new to the Center for Healthcare Strategies, first of all, welcome. We are a policy and implementation partner dedicated almost exclusively to Medicaid. We do a lot of what we're essentially doing today, elevating effective models for prevention and care delivery, zooming in on pockets of the country, doing innovative work, and making sure that you understand them so you can apply it to your own local context. Next slide. So here are the beautiful faces that you will see today. We will have Adriana Salinas from Kern Family Healthcare, Sanjita Datta from SD Healthcare Consulting, and Sonia Dillon from SD Healthcare Consulting. I am also joined by Melora Simon, Associate Director at the California Healthcare Foundation, and she's been doing some amazing work zooming in on CalAIM specifically. Next slide. So you may be new to the California context. I know that we have California stakeholders as well as national stakeholders on the line. CalAIM, short for California Advancing and Innovating Medi-Cal, was launched in January 2022 and is a multi-year care delivery and payment reform initiative. It often has 2 major components, enhanced care management and community supports. And essentially what we're talking about today are community supports. Those are optional managed care services. So managed care plans do not have to provide them, but they can elect to provide them. And California was innovative in that they used this framework to address health-related social needs, like food and housing and security. Because they are optional, service uptake varies across counties. And so we're zooming in on Kern County in particular to really see what some of these services look like. And community supports as a concept are designed to avoid, for example, nursing facility admission, inpatient admissions, emergency room usage. So really thinking about strategically leveraging and expanding access to existing services. So you may hear about the in-home supportive services program in California. That's an existing program that provides similar services. And essentially, community supports are designed to expand access beyond that, perhaps during a waiting period for in-home supportive services, perhaps meeting the member needs despite what is initially approved under the in-home supportive services program. Similarly, California has other asthma-related services available, including asthma prevention services. Asthma remediation as a community support services moves beyond what is typically covered as a benefit and really thinks about environmental triggers in the home that can be remediated to address the members' needs. And with that, I'm going to turn it to Melora Simon.
Thanks so much, Diana. It's great to be here. As Diana explained, community supports are optional. And what we see in the data so far, we kind of know what's going on across the state through the end of the first half of 2023, is that the use of community supports is really concentrated in 3 services: housing navigation, medically tailored meals, and housing and tenancy sustaining services. And so what we're seeking to do with this webinar series is to actually go deeper into some of the community supports that are less well adopted, and to really shine a spotlight on communities and regions that have embraced some of the other community supports, to show how they're doing it, what workflows they've set up, how they found partners, how they've brought in different referral pathways to identify people that might need these services, and how they're setting them up to be sustainable. So that's really what we're here to do. We had our first in the series back in January, going to Orange County and looking at rehabilitation and sobering centers. And today we're going to Kern County to talk about personal care and homemaker services and respite services, which are similar but in different situations, and then also talking about asthma remediation. If we go to the next slide, before we turn it over to Kern, I just wanted to also highlight that here at the foundation, we've really set up a resource center to help implementers understand and unpack all that is CalAIM. So just a kind of brief plug for our resource center, which specifically has a section devoted to new Medi-Cal providers. But without further ado, let's go to Kern County and hear from Adriana.
Hello, hope you can hear me. My name is Adriana Salinas. I am licensed. I'm a licensed marriage and family therapist, and here with Kern Health Systems, I am the director that oversees the community support service through the county initiative. Next slide. As mentioned earlier, the purpose of community support services is to provide cost-effective alternatives to covered services. Our biggest goal here, and especially in Kern County, is to ensure that each of our members are provided with the wraparound model, meaning that we are not just looking at their medical needs, we're looking at their holistic needs, starting from their psychosocial all the way to their medical. And in hopes that we reduce recidivism into the hospital or divert them from going to a higher level of care. Next slide, please. Today we are going to talk about 3 of the current services that we have. Kern County currently has 13 of the 14 services that were pre-approved by Department of Health Care. And we're talking about the 3 that we partner with FD Consulting in. One of them is the asthma remediation service. The other is the personal care and homemaker service. And the other is the respite service. When we first launched community supports here in Kern County, we were trying to determine which of the 14 was the most needed in our community. And we definitely found that asthma remediation is one of the services that here in Kern County was highly needed, simply because of the air quality that we have here in Kern County. A study back in 2019 by the local public health department announced that over 111,000 individuals in Kern County have some kind of asthma-related services. Through our own stratification within Kern Family Healthcare, we found that 27,000 of our members had asthma-related complications or had been to the hospital because of asthma. So we definitely wanted to make sure that when we started this program, asthma was on the forefront of our needs. Following every model of care, we were able to incorporate additional community support services, and we looked at the personal care and homemaker service as another high-level service that was needed here in Kern County. For the personal care and homemaker services, we work alongside our local aging and adult service to see which one of our members are already receiving in-home support services, and just do a supplemental amount of hours for those individuals who are still having difficulties with their daily ADLs. Then our last one that we have partnered with SD Consulting is our respite service. This is where individuals are who are caregivers are allocated hours to be able to attend to their own needs. This can be in lieu of having our members go into a higher living facility because the caregiver is unable to care for them. So we definitely want to make sure that we implement services for the caregiver to avoid burnout or avoid them missing their own medical appointments. And next slide. So here in Kern County, we stratified some of the numbers that we have for utilization regarding asthma remediation. As you can tell, asthma remediation was started with us in 2022. We had very few members because very few members knew about our services. As we continue to outreach and continue to educate our membership about the services that we offered, our numbers have significantly increased. With the support of SD Consulting and our other CBOs, they have been able to go in, either provide the product that our members need or the remodeling of necessary requirements that our members need. We've been able to open and close several members throughout since 2022. As you can tell here, at a highest peak, we had 176 members open to Kern Family Healthcare for asthma services, asthma-related services. Next slide. For personal care and homemaker service, we also conducted and analyzed some of the data from the service. We started in this service in 2023, so this hasn't been live very long, but as you can tell, it's well utilized. And here in 2024, our first quarter showed that we had up to 110 members open to the services. And as we continue to grow and outreach, I foresee those numbers becoming a lot higher. Next slide. And finally, our respite services that also went live in 2023. Again, the trend is as members become aware of this service, as our outreach continues, our numbers continue to grow. The blue indicates how many members have been closed, which means that these members have received the services and have received the needed amount of hours required for them to become successful. And currently right now, in 2024, we have 60 open cases and 24 referrals pending. Next slide. And again, we here at Kern County have 13 of the 14 services available to the members in the community. We love our partnership with SD Consulting. We've been partners with them for almost 2 years, and we hope to continue additional services with them. I've allowed my phone number, my direct phone number, and my address if you have any questions at all regarding any of our 13 services that we have live right now. And that's it.
Wonderful. Now we'll turn it over to Sanjita Datta.
Hello. Thank you for the platform. I really wanted to say thank you to CHCS and Adriana to give us the platform to explain the services that Adriana just talked about. We are providing services in Kern County in connection with the Kern County help and support there. I'm going to have my partner introduce as well right after I introduce myself. So because she's the partner with me providing all these 3 services. I'm an RN BSN myself, going to school right now for FNP, co-owner and the project manager for a few of the services that we provide at the SD Healthcare. Sonia, would you want to turn your camera on and introduce yourself and then we'll go through the slides.
Sounds great, Sangeeta. Good afternoon, everyone. My name is Sonia Dillon, and I am also part of SD Healthcare here in Kern County. And I'm a registered nurse myself and been living in this community in Kern County for 25 years and been an active member and part here. So this project and this program is very close to my heart, and we're enjoying doing it together. Thank you.
So as Sonia and Adriana, everyone explained all the three services, we actually started with the respite services in July 22, and then came to know that there are several other needs in the community, as Adriana talked about, and we submitted the letter of interest for Homemaker services and also asthma remediation, which we started in July 2023. So we've been providing these services for the last 2-3 years now. We felt respite care services because me and Sonia both do run home health and hospice, and we saw the need of respite care very much in the community firsthand, where members do lack support at home, and they were utilizing the hospitals a lot more, ER visits a lot more, and how could we reduce those services out there and also help in rehospitalization, not to have those things going on. Also, when we went to the asthma remediation, we looked at it and we were thrilled to do something for the asthma remediation, being nurses, Sonia's partner as a respiratory therapist himself, and we were just looking into this. We teach this in home health and hospice arena a lot, how to manage the environmental barriers in the community so that they are not reaching out to the hospitals or the ER urgent cares and then taking care of these things at home, where we can have these services empower them to take care of their needs themselves at home with the asthma remediation program. Next slide, please. So going to start with the who is eligible for respite care services. Respite care services mostly addresses towards the caregiver burnout. What we look for the eligibility is the individuals who do need help completing their ADLs, who have complex needs with the medical needs because they need someone else's help because they have taxing effort to complete their own ADLs. It's also with the members who are caring for their loved ones and they are feeling overwhelmed taking care of their loved ones. We, as respite caregiver services, we can provide them caregivers from our services to relieve some of the stress that they are going through. Then also, we enroll the members from the children's. We have very few children pediatric services that we are providing right now, but we are looking forward to provide more and more. But we do provide some respite care to the working moms or caregivers who are there, give them some additional hours to take care of the respite care services for the caregivers or the family members who are providing services to their children. Next slide, please. So eligibility for personal care and homemaker services do come in if they're not able to complete their ADLs themselves and they do need services to complete these ADLs with the assistance of another person. There are personal care is not something that is just limited to the IHSS services only. Current health system has come up with a plan where they do authorize us with the personal care hours, and our caregivers can go out and provide these services where caregivers can actually go in and help and then have the tailored needs of the individuals or members in the community and help them in the comfort of their home. Homemaker services, on the other part, is the in-home support services, and we go additionally on top of the in-home support care services individuals. with the extra additional hours. And then we provide the services exactly the same as in-home support services individuals will be providing. Of course, these all require the authorization, and we do provide these services to the individuals who are needing more hours because they had a change in condition, because they had recent rehospitalization, or they had some surgical procedure that got done in the hospital. And now when they came in, there is a big change in condition, and in-home support services hours are limited, and someone else needs to come in and fill in some more hours to provide that services to them. So they will not be put into an institutionals like skilled nursing facilities, or they have to be staying longer in the hospitals, but they can be in the comfort of their own homes, and then we can provide these services to them as extended services to the in-home support services. Next slide, please. So what is the difference between the caregiver, respite, and homemaker services versus the in-home support services? California does a great job in providing the in-home support services to the members in all California. But the caregiver, respite services, and homemaker services, like I was explaining in my other slides, it is a short-term service that is authorized by the group that we work with. Right now, we're working with Kern Health System Group. And what happens over here is that we are the extended services to the in-home support services to provide the homemaker services. And the caregiver respite services is mostly designed towards the caregiver burnout. So we are providing services to the caregivers so we can go fill in, and the caregivers can go and take care of their own health, their own time off, what they need, because they've been doing it for so long, or they're feeling burned out, or they're overwhelmed, and now it is costing them to take care of their own health. Or even something very simple would be that they're not even able to take a long shower because they've been taking care of these individuals for so long, or they cannot go in and do a grocery shopping because they cannot leave their loved ones in home by themselves. So our services come in handy at that time, and then we go in and give the relief to the primary caregiver as per the respite services, so that they can go in and take care of their own needs and get the break at the same time to rewind, and then come back with the fresh mindset to say, okay, I got some relief and now I can take care of my loved one. Next slide, please.
I would like to add something to that,
Sure.
Sangeeta.
Yeah.
Just really quick, under homemaker services, also, we do take our patients, our clients to doctor's appointments and grocery shopping. Some individuals just live alone and they have no help. So they schedule their appointments when our caregivers go, and they drive them to their appointments. They drive them to any activities that they need to do. We have a limited hours that are set up that way, but we do provide those services on top of, when their in-home support services person goes, or on top of it, we provide those services as well. Thanks.
Yeah. Being nurses, and I'm sure as healthcare workers, we understand and acknowledge the importance of the social determinants of the health, that how these services will be helping them out, and then keeping the healthcare costs down, and at the same time, empowering our members in the community, so our hospitals are not overwhelmed with some simple problems that the members are coming in, because we can educate them on that. And then we do continuous caregiver education as well for our team at SD Healthcare. Yeah. Next slide, please. So the third service that we provide is the asthma remediation. And as we were talking about how we were so thrilled just to see out that there's something more healthcare related, being nurses, being respiratory therapists on our team as well. How can we make an impact in Kern County with asthma remediation, and what does it bring to the members of our community, and how can we keep this service going and also help our hospitals or the institutions in the community to not have the patients or members who are just getting the asthma exacerbations all the time, and then they need more medical help. What we do as asthma remediation community service, we actually look at the physical modifications in the home environment to make sure that their health, welfare, and the safety of the individual is intact, and how can we make it better to empower them to make sure that they are taking care of themselves. It also enables the individuals to function in the comforts of their own home and not to be in the facilities or hospitals with the acute exacerbations. It prevents the acute asthma episodes, as I keep talking about the exacerbations, resulting in the need of the emergency services or reaching out to the providers to make urgent appointments or use of the urgent care services, or the hospitalization eventually when it goes to the point where they need medical services. What we do for asthma remediation, we do provide a lot of education. We use a tool that is called a zone tool, which has a blue light or blue portion of it, that what do you need to do every day. The tools and resources that we are giving it to you, you should be checking your O2 sats, let's say, or you have to vacuum your house weekly, or all the environmental barriers that we educate them about. Then there is a yellow light on it, and there's a red light on it, and there's a green light on it. So whenever you're dropping to a yellow light, you know that you need to go back to the green, because if you don't take care of yourself in the yellow light, you're going to drop to red, which brings you to the emergency services, hospitalization, and all that. So there's a good tool that we use for the asthma remediation and empower our members in the community to stay home and at the same time prevent the asthma exacerbations. Next slide, please. Who is eligible for asthma remediation? So like we have been talking about, anybody who has reached out to the emergency department with the acute exacerbation, or they had recent hospitalization. There's a typo here on the slide. It's not too sick, it's too sick. So there's if you're too sick and your pulmonologist or your provider states that you will be needing some kind of asthma remediation services, and your asthma control test score is 19 or lower, they can be the eligible candidates for the services. They had any ER or an urgent care visits in the past 12 months or recent, they will be eligible for that. And the providers, like I said, their pulmonologist or PCP or any other institution that they state that they are having a lot more of the asthma flare-ups, they will be eligible for these services. Next slide, please. So these are the examples of asthma remediations. We keep talking about the home remediations or home environments that we work with. So what we do is we work with some encounters for asthma remediation. We provide them with a lot of tools and resources and supplies. So these are the stuff that we do, some allergen impermeable mattresses, mattress covers, beds and pillows that they can use, that can be dusted easily and are not collecting the dust. High efficiency filtered vacuums. So we do supply those things. We have asthma friendly cleaning products. some minor mold removals and remediation services we do. We have contracts with the carpet cleaning services. We are also looking into many other things that we can probably make some vendor contact and then see what we can do in terms of some small, like I said, mold removal, little stuff that we can do in their environmental change so they can be empowered to be taking care of themselves in the comfort of their own home and reduce the exacerbation of the asthma acute episodes. Next slide. Where do we get for these referrals and who can initiate these referrals in the community? So of course, we do have a lot of community outreach where we go out. Sonia would be able to talk more about it. She's the queen of community outreach, and she works with one of our community health worker. And we go to many places, providers, hospitalists, the discharge planners, the other community services. We do meet them in our community outreach areas, and at the same time, we do meet them at the CALIM meetings or any current health meetings that we have or webinars where we get the information of our partners in the community where we can talk to them about our services. Of course, for the Homemaker services, we do reach out to the IHSS team. If they have a long list of members who are applying for the additional IHSS hours and they are having some difficulties or challenges approving those right now, or they have a long list of it, we come in handy and then provide those services as well. And overall, I would say just the community outreach in the events, we put our booths out there and then just make sure that our community awareness is out there, that these services are available to the Current Health members. Sonia, would you like to add something?
Yes, I would. So when we first initially got this programs, we sat down and decided like, how are we actually going to do this? Do members know about it? Adriana and us, we had a lot of meetings, like how do we outreach, what they're doing, what we're doing. So we really decided right off the bat that we need to have a community liaison on our team. We need to have a community health worker on our team, and obviously our office staff to do the outreach, because in the beginning we thought when we got the programs that we're just going to get all our members referred to us. But in realization, we realized the programs are so new, the members don't even know about these programs. And all the programs were kind of interrelated. For example, we go into a home, they need homemaker services, and later you realize their family member actually, wife needs respite care services. And then they're also asthma members, they need services for food, transportation. We're finding a lot more when we go into these homes. So when we're educating about our programs, we educate about all 14 programs and give them information to contact Current Family. And so that's kind of how we started our organization. And really outreach was the way how we're trying to get our numbers up. And I think if you can put the next slide, I think that's about the community health workers. Oh, actually, this one is, so then we made obviously educational materials to take it to all the, events that are done in the community, doctors' offices. We definitely meet with the case managers at the hospitals who are discharging members, so especially asthma patients. And if they are holding a discharge at the hospital, what can we offer in the interim, and then patient can be discharged, not stuck at the hospital meantime. So we do contact Current Family and get those authorizations expedited, like within 24 hours. We get an urgent authorization, usual standard procedures between 3 to 5 days. So we personally reach out and get those members help faster than normally. So these are our education, our flyers that are out in the community. We have them, all of them in Spanish and English, and hopefully in other languages in our county. But Spanish is more. Our members are more in our community, and we have Punjabi speaking, Filipino, Tagalog. So we have different languages that we are working on in the future to have our educational material. Next slide, please. And then like I started with that. So the main reason I feel like why we're successful with our program outreach with a partnership with Curtin Family is having community liaisons with us. So we have 2 on our team and a social worker on our team as well. And one of our community health workers, obviously, she speaks Spanish. So she goes out and does all the outreach and all the outlying areas in the community and educates the staff, the physician, and even in communities. So she does a lot more than just talking about respite care, homemaker services. So when we're in that home, most of our patients are elderly and have a lot more other issues going on. So we educate them on all these services as well while she's there. And I think that platform is working for us. Would you like to add anything, Sangeeta?
Yeah, no, you said it very well. Community health workers are taken as trusted partners out in the community, and their awareness when they go out and talk to the community clinics and even in the groups or wherever we are putting the events together, these trusted partners are the ones who are actually making the impact in the community by empowering people and educating and spreading the awareness to let them know that this is the service that is available in the community, that they can avail the services. Because anytime we talk about free services, many people get suspicious or scared about solicitation and all that. So I think these trusted partners do a great job when they go out and they are educating about our services. And Sonia said it right. When we started, we saw the need of the community liaisons right away. And in 2022, July, when we started the services, we were like, oh, where are the members? Why are we not getting any members? Why are we not able to provide this free service that is available in the community? Why people are not availing these services? And we came to know very soon enough that people are just not trying to get to, because when they hear the word free, it's like, oh, I don't know when that invoice is going to come to my home. And that's where the community liaisons, the community health workers were very helpful, and they were educating and empowering people out in the community, not only just the members out in the community, but the community health members, healthcare workers, hospitals, discharge planners, everybody. So it was not just the layman people, it was also the healthcare workers as well, just to let them know that these services were available.
Yes. Next slide.
Here's the referral form that we have created. We would like to have our partners, community partners, who actually get these referral forms at each visit that we do. Our community liaisons, they actually send this out, and then this gets filled out by the referrals resources, and then they fax it to us or email it to us, and that's how we get our members to our services, and then we provide them services by obtaining the authorizations. I think I'm going to wrap it right here, but Sonia, go ahead.
Yeah, I was just going to add, so once we get this referral, that's how we enter the referral in Kern Health System for authorization. So then we know what their needs are. So the scoring of each member is different, and that's how the hours are allotted for care. A person who's bedbound might need more hours versus for homemaker and personal care. The hours are allocated according to their need. So once we get the referral from the hospital or doctor's office, so then we enter in Kern Health System, and that's how we get our authorization. There's max numbers and there's how many they during the day. So this kind of defines it for us. So next slide. Okay, I guess.
Thanks very much. I think we're gonna start with questions about personal care and homemaker services and respite services. And we've got a number of questions that are coming in through Q&A that are about kind of coordination. So how do you coordinate between these services and hospice services, and how do you coordinate with these services and IHSS services? So why don't we start with hospice?
So coordinating the services for the respite services with the hospice is hospice services, because since we do know the hospice services has its own guidelines, respite services for hospice are only done in the facilities, in the skilled nursing facilities that are that the hospice has the contract with. So our respite services are not the respite services for the hospices. So I wanna separate these two out. Our respite services are to give the break to the caregivers in the home who are feeling overwhelmed, or they need to take care of their own medical health or anything. But the hospices cannot use this respite services to have a patient being on respite services under the hospice care. So that will not be paid to the hospice. And I don't want to talk too much about hospice over here. That is more hospice. But I want to clarify that this service is only for home and to give the break to the caregivers at home.
So I can quickly add to that, Melora. So since when we go out and educate in the community, we tell other hospice companies, if you do need, we provide care to your patients, to every patient in the community. So it's just like 3 to 4 hours a day. The caregiver gets a break. I know they get a home health aide every day or 3 times a week. So this is just addition to them to help them, because there is definitely burnout in that industry, caring for long-term Alzheimer's patients or things like that. So that's how we do it. So it's open to our whole community, and we get referrals from different hospice companies.
Thanks. So let's say a member who has IHSS has a change in condition. Would they be referred to you, or would they be encouraged to request a reassessment of their IHSS hours?
So this can come from many places. If they are in the hospital, our liaisons go into the hospital, and they can also reach out to us. And if they do require extra help because maybe the member has applied for extra hours already because of the change in condition, and they're not able to get that from the IHSS services right now, we can apply for the authorization for the extra hours with the KHS system. Once we get approved for those extra hours, our caregivers can go in and provide the home care services additional to the IHSS services to provide the care to the members.
And I will add, I'll add to that too, because in-home support services, they also have their own case manager. So when they call the case manager, she comes and does the evaluation, but the process takes a little time, like 30 days. I think usually turnaround time is 30 to 60 days. So in between those 30 days, we can provide our caregivers. So when they go there, they notify them, then, oh, we got extra support. And so I think the two systems are still trying to work out a way to talk to each other, the social workers, theirs versus our team. I think we're so new. Hopefully we'll get a better system in another 6 months or a year for sure with them.
And it sounds like in general, with both IHSS and with hospice, you're filling in the gaps.
Yes.
So either as a bridge, or something that those other benefits don't cover. My next question is for Adriana. We don't see a lot of plans offering this. And I'm kind of curious to the extent that you can speak to it, if you know kind of what led the current family health plan to offer the service. What was the motivation, and what just say more about kind of how it got started.
Yes, actually, all 3 of the services are 3 pre-approved services through the county's initiative. And we already had a partnership with SD Consulting and knew that they did an amazing job. So it was kind of like our intent was to work with them because they are already in the home. So why not take that opportunity while they're in the home to evaluate other needs that they're very familiar with. As stated, Sonia's husband is a respiratory therapist, so asthma just seemed natural. They had the staffing, they had the means, and they had the profession to do it. And the Homemaker services, they were already in the home doing other services that just linked with adding on those homemaker services and respite care. So we just got really lucky. I mean, we just got really lucky that we hit a CVO who hit every single dot.
Oh, thanks.
You talked about all the different ways that people can be referred. If you had to kind of choose your top 2 or 3 referral pathways, like where much of the volume is coming for these 2 services, not for asthma, but just for these 2, what would you say they are?
Well, we definitely always encourage individuals who either contracted with Kern Family or not contracted to either use our provider portal, or we do have a document they can use. And we are always looking at partnering with individuals with aging and adult, Department of Human Services, the foster care team, and definitely county agencies who have the population that we service.
Yeah, regional center
Mm.
and doctor's offices also you get a lot. Yeah.
That's super helpful. Diana, is there anything in the chat that I've missed that we should try to cover before we move on to asthma?
Yeah, it might be helpful, and certainly this is perhaps a question for Adriana. Tell us a little bit more about the payment structure, as well as what the initial approval period is for personal care and homemaker services.
Definitely for personal care and homemaker services, Kern County is a fee for service. So when we assess the needs of the member, and then we will allow an allocation of X amount of hours based on the member's needs. And our authorizations are typically 6 months. And we would definitely, we look at after the 6 months, the medical necessity to continue additional hours or discontinue the services at this time. There is a cap on, I believe it's.
Yeah, there's a cap. Mm-hmm. Yeah.
So that's not put through us; it's put through DHCS. So we have to work diligently with our internal team to make sure that the authorizations don't exceed that. Did you have a second question? I'm sorry.
Yeah.
Anything else, or should we move on to asthma?
No, that's it. I mean, just our referral process is we do the initial assessment of needs. We send over the referral over to our community-based organization. Typically, they're authorized within 72 hours. We don't want there to be a hold on anything, and we look for the least amount of time that it could take somebody, the better. We do know that for some of the services, contacting the member, doing some outreach might be difficult because of the population that we work with. But we hope that that's the only barrier, not the authorization process or anything else.
We were just talking about payment, about the other community support. When it comes to asthma remediation, it's everything from the assessment to, potentially like mold remediation or installing a, ventilation system. How do you manage the payment of that?
Asthma remediation is a little more difficult for us because there is prerequisites to asthma remediation. The SD consulting team, prior to having the authorization for either the purchasing or the modification, have to present to us a home visit documentation. The home visit was conducted, that there's an order by a physician or a respiratory therapist that it's needed, and then an evaluation of the needs. Once we get those 3 in, we go ahead and submit over to SD Consulting the referral, the green light, saying we've got the prerequisites. Please begin to service these individuals. Here in Kern County, we do things a little bit different, where we have assessed how much material costs, how much product costs, and we put it in 2 different buckets. So we work closely with SD Consulting to tell us if they need funds for the purchasing of material or for the construction of modification. We're currently working our internal process to change that, just because we know that labor has gone up. There's been more expenditure than there was 2 years ago. So we're hoping to modify that so that we can release more money to our community-based organizations, since we do have $7,500 to work with.
Yeah, for example, like each of these visits, Melora, it takes at least 4 to 5 visits. I know it's 2 visits, but by the time you go, a member's not there. You go there, you deliver, and then you have to teach them. The member's not there, so it takes a lot more visits than what we have actually set up in our, contract. Like 1 visit and the second visit to deliver. It ends up being more than that. Has been our experience, with the program.
And we haven't seen this in the chat, but I've heard it kind of from folks anecdotally. If it is something like pest removal or mold remediation, how do you find a general contractor or a pest removal contractor that has an NPI? Or do you guys manage that? What's the kind of interface between these very non-medical services and the structure of community supports, which requires healthcare codes and billing?
So
I believe sorry,
Go
go
ahead.
ahead, Adriana.
the way that we process that is we allocate that, that responsibility to the CDO. They each have their own contractors that they utilize. All that we request is the invoice for the services, and they're reimbursed. I forget. I'm sorry.
I think I just wanted to add it because you did say NPI. We do look for like a licensed contractors where we can trust them with our organization, and then we develop those contracts with them. Like I did talk about carpet cleaning and these home modification services. So we do work with the contracted vendors, and then we submit our invoices for the services that they provide.
You won't even believe that guy's our carpet cleaning company. The carpet cleaning guy, he was a respiratory therapist. I don't know how that happened, but we just got lucky there too. So it's been very interesting. It's been fun doing that
The universe
project.
is aligning everything.
I guess so. That's what I
Yeah.
have to say.
Yeah.
So.
I see another question, just a clarification about, this is for Adriana. Are there kind of different expense buckets or limits for, visits for assessment versus like, installation or actual equipment?
Currently, there is. We have, like I said, we have 2 options, but it's a flat fee. And we did that because we didn't know what we know now. We didn't know the volume, we didn't know the cost. And so as we become more familiar, more seasoned in community support, we're seeing that there needs to be modification to be able to provide more services to our members and to become market fair to our CBOs.
So we have like 2 encounters, and like encounter 1, we have all small services or probably more supplies type of services that we provide to our members to keep them home in the comfort of their home. And then, that will have the cleaning supplies or finding their inhalers, like I can't even remember the word. What is it? Yes, thank you. Yeah, so those kind of things that are very small services, and then the encounter 2 goes into the bigger services where the home modifications and all those kind of come in. So that's how it is bucketed in the 2 encounters. Yeah.
And I see a couple more questions about the other services, but do you see anything about asthma before we maybe flip back?
Yeah, so, and this might be a good question to perhaps, tee up a broader focus, but I see a couple questions on community health workers. What does the intake form look like? How are they determining tasks? And I also see a question about the asthma preventative services benefit, and that's often something that's provided by community health workers. So giving us a little bit of picture of, the community health workers' role and some of those process elements.
I'll defer to SD. They have wonderful community health workers.
Currently, I was gonna add that earlier too. The community health worker, we actually just hired her full time for us. So she really hasn't. I think one of the questions was how does she get her hours authorized and reimbursement from current systems? We have started that process, but she is not getting reimbursed for her hours and visits from current health system as a community health worker yet. Currently, we have her as a community liaison full time, so we really don't need to worry about her hours and allocate. But she's the one she's available for us every day, 5 days a week. So she goes out and does all the evaluations and teachings and things like that. So she is actually doing a training in asthma also currently, because she did more of her training in end of life care, palliative care. She did more of those services, but right now she's getting her certification. I think there's a class that you take for asthma education too. I'm not sure if that was the question, but I think I was just reading the hours, how they're allocated. Adrienne, I don't know if you want to answer, like, how do you pay or how do you do the other community health workers? I'm not,
Yeah, unfortunately, we have been in search for community health workers, but there are trainings that they have to have, and we haven't really had a lot of those here in Kern County that have that certification. So I believe we probably have within our network maybe one or two. I know FD Consulting is really starting to get their CHW up and going. But there is a G code that our community health workers use to be reimbursed once they're credentialed with the Kern Health System.
So we've started the credential process and submitted it, but we haven't used a code yet to, for her reimbursement yet. I'm not sure other counties have them. Maybe we can get more help.
Tell us how you're getting them, because we have been in trouble.
I know. We are definitely encouraging a lot of people, especially, with people, Punjabi speaking communities really big here in Kern County. So we're encouraging a few people to really go out and do the training. And so we're trying our best. I think we have got one right now. She's really interested. So let's see.
Here's another kind of big picture question. If you were talking to, I'll start with Adriana, if you were talking to another plan that was interested in launching these services, what advice would you give them, or kind of what lessons learned from your experience implementing this program so far?
I think since the launching of this program, our goal and even our mission for Kern County Healthcare is we are a local plan, stay local. We have been very fortunate, with SD that they are a local plan. They're invested in the community. They know the resources in the community. They know the population. So I think that investment is the most important thing, because we have a plan for medically tailored meals. Most of them are either in different states or in different cities. And we just do not see the motivation for outreach with CBOs who are not within our community. So, if I can give that as an advice for it to grow, there needs to be invested by the CBOs.
Thanks so much. And same question to the team from SD Healthcare. If another provider approached you about kind of doing these 3 community supports, maybe somewhere else in the state, what advice would you have for them? What kind of lessons have you learned along the way that might help ease their way?
I think the insights that we would like to share is the addressing the unmet needs in the community. By standing up for these services, we have the opportunity to fill the critical gaps that we have in the continuum of care and improve the health outcomes of the vulnerable population that we work with, low income, low literacy. We do see a lot of gaps right now that we can fill in with our 3 services that we are providing. Other thing that I would say is acknowledging the holistic approach to the care, the importance of the social determinants out in the community, addressing those, providing more comprehensive care that addresses the diverse needs of our community members. Sonia has talked about many times how many Latino population is there, the Asian population is there, and then we do hire or recruit our caregivers, also very diverse population, so we can provide the language barriers by providing them the same language speaking caregivers, so they are comfortable and more open to have the services from these community caregivers. The other focus, I would say, by providing the 3 services that we see in the community is the preventative focus. I'm so surprised, and I was talking to my team the other day, how many times do we hear that our member has gone to the hospital and we have to hold the services for this member? I believe in the last 2-3 years, probably 5 or 6 members that we have heard of that has gone to the hospital, and we have to hold services, which I see a lot more happening in my home health and hospice world, which makes me feel like, oh, we're doing something great in this Kern County with these 3 services there, because we don't see as many people running to the ER visits or getting hospitalized there, where we have to hold the services, tell the authorization people that, oh, we need to hold services. So I think preventative focus is very profound with these services out there. The last piece that I would touch upon is the collaboration and the partnership. I believe by working together in a community, we all can create a more integrated and cohesive system where we all are meeting the diverse needs of our community with the services we provide as the CBOs.
Well, thank you so much to our amazing panelists. What wonderful words to end our webinar on. I really appreciate all the themes that we discussed today. And thank you. Thank you so much.
Thank you for giving us the opportunity.
Thank you for having us. We really appreciate it.
Thanks so much to everybody from Kern for sharing your story and experience.
Thank you.